Thank you very much, Laura, for the kind introduction. I would also like to thank the organizers of the symposium, Carlos, Sandra, Laura, everyone, and the conference for the kind invitation to be here. So these are my disclosures. In 2021, 85% of people living with HIV knew their HIV status. 75% of them were accessing treatment, and 68% of those were virally suppressed. Although the focus and progress of the second of the 395s of the UNAIDS goals has been critical to reducing morbidity and mortality, these targets were missed at the global level. The seemingly small gaps add up to leave 1/4 of people living with HIV globally not on treatment, and roughly 1/3 with unsuppressed viral loads. In particular, the targets for virologic suppression have not been attained in many low and middle income countries. In this context, long-acting formulations hold promise to improve treatment outcomes. Randomized trials have shown that monthly long-acting injectable CAB plus rilpivirine is non-inferior to oral ART, and 2-monthly CAB rilpivirine is non-inferior to monthly injections. The studies enrolled a majority of participants in high-resourced countries, with very few participants enrolled in LMICs. This regimen is being rolled out in several high-income countries. A modeling study predicts that in sub-Saharan Africa, injectable CAB rilpivirine is best targeted to those with poor adherence, HIV viral loads higher than 1,000 copies, in whom cost effectiveness is greatest. Furthermore, the risk of contributing to further resistance is lower than continuing on failing oral ART. In this slide, we can see the major studies ongoing or close to start. Unfortunately, studies with islatravir, a quite promising long-acting agent, both for prevention and treatment, were put on full clinical hold due to an unexpected toxicity. Other promising agents, such as lenacapavir, are under investigation and may prove particularly useful in heavily treatment-experienced adults. The most extensively studied regimen is CAB rilpivirine, administered intramuscularly every 1 or 2 months, and the remaining of this presentation will focus on this. As you could see in that slide, there are very few long-acting ART studies in low and middle-income countries, and I will just target a few of them. The CARES trial is a vital stepping stone for bringing injectable ART to treatment programs in sub-Saharan Africa, gather robust evidence to support its use in Africa, as well as to build experience before large-scale implementation can happen. The large majority of the 512 participants have already been enrolled at sites in Uganda, Kenya, and South Africa under the great leadership of Dr. Sisi Kitiu from the GCRC in Kampala. The Impala study will also be conducted at sites in Africa and will target participants aged 18 to 25 with a history or at risk of suboptimal HIV control. The target population is MSM, sex workers, transgenders, drug users, all between 18 to 25 years old. This study will start enrolling very soon. Another one that I could get some data was the LATA study. It was not very easy to gather data on these studies at all. The LATA study targets individuals aged 12 to 19 years old, also in Africa, and is not yet recruiting. So we will now discuss advantages and barriers related to the drug itself, to the persons who are in need to use long-acting ART, and to the healthcare systems. Historically, the introduction of evidence-based technologies into public health programs have been fraught with delays that result in missed opportunities for impact. These delays have in part been due to the lack of preparatory evidence that is critical for introduction into programs at scale. Product registration timelines in LMICs are usually longer, and sometimes they never occur. So I will now move to discuss a few of the drug level advantages and barriers for the CAB-rilpivirine combination. So among the advantages, it of course increases choice. That is very important for all of us. It is invisible, discreet, and less stigmatizing. It facilitates adherence. It can be used as DOT. It obviously has less frequent dosing and is an RTI-sparing regimen. Among the most important barriers, there is this oral lead-in phase that can be an issue for people who deal with issues related to adherence. It has injection site reactions. Very importantly, for our countries in low and middle income countries, there are drug interactions with rifampin. There is the issue related to transmitted resistance that is very high in our countries for NNRTIs, and the issues related to not having resistance testing prior to initiating therapy. And also, it's not adequate for individuals co-infected with hepatitis B. About the individual level advantages and barriers, it's very important that its potential use targeting those who struggle most with adherence, and that's a major advantage. And on the other hand, barriers are related to more frequent clinic visits that we are having for oral antiretroviral therapy. We can have gluteal injection site issues related to obesity, to implants, tattoos, related also to patient access because it increases resources related to transportation, for instance. There is insufficient data in pregnancy and breastfeeding, as well as among children younger than 12 years old. And system-level advantages and barriers can vary a lot among the different countries, the different health systems that we have. So in regards to advantages, there will be probably less treatment failures with less hospitalizations and lower healthcare costs. But there are issues related to increased clinic volume. The cost of the drug is higher, the need of a cold chain storage capacity, staffing, the issues related to pretreatment genotyping, as I mentioned, and the tracking system for the injections. That is something completely new for us. Long-acting ART brings challenges for the current differentiated service delivery building block that will need to be adapted to needs. Being aspirational with more advanced long-acting ART used and an optimized differentiated service delivery model can be developed. Use of non-traditional health models, such as community-based organizations, mobile vans. Under investments in the HIV response at global targets for 2020 were missed. This has translated to more people living HIV infection who are in need for services. To get back on track to end HIV, we largely determine who has access to HIV services that meet their needs, who is dying. And this includes the context where people living with HIV are located. We are pandemic that is far from over. If we do intend to end the HIV epidemic, we cannot overlook. This also needs to be taken into account when evaluating the feasibility to incorporate new ART strategies, to incorporate options that can improve quality of life and treatment outcomes. I would like to me with this presentation, and thank you very much for your attention.